Welcome. My name is Michael Mallinson. I am the President of the Canadian Spondylitis Association. On behalf of the following patient groups, the Canadian Arthritis Patient Alliance, the Canadian Skin Patient Alliance, the Canadian Psoriasis Network, and the Canadian Spondylitis Association, I am pleased to introduce Dr. Neil Shear as this evening's speaker for Biologics, Your Treatment, Your Choice. Dr. Shear is the head of dermatology at Sunnybrook and Women's College Health Sciences Centre and is director of the University of Toronto's Drug Safety Research Group. He has published over 200 peer-review papers and is chair of the Canadian Association of Professors in Dermatology and president of the Canadian Dermatology Foundation. Please welcome Dr. Neil Shear.
Welcome. I'm Dr. Neil Shear, and I'm going to be speaking to you about Biologics, Your Treatment, Your Choice. Before I start, I would like to explain that I have worked with some pharmaceutical companies, and these are listed here. This is something we do now as a standard procedure so that you understand that we have worked with several companies and often are being paid for doing these things. Also, during this presentation, I hope you have a chance to write some questions if you need to have any answered, and to stay at the end to hear other people's questions and the answers to those. So what are biologics? Biologics are actually an important class of drugs, and they've been around for a long time. And when I say drugs, I really mean therapies, things to make us better. Traditionally, we have aspirin, which is one of the oldest chemicals that we've used for treatment, and we're still using it today. This is from the late 1900s. Now, during that time, we found other medications like insulin. Insulin was taken from actual animals and had to be isolated. But over the years, we've learned how to tame small bacteria and other cells to make insulin. When you get insulin today, it's a biologic. It's made by cells, and it's made in a complex process. Since then, we've had even more complicated biologics. These are often called glycosylated biologics because they have sugars added to them. These are very large molecules. The other term that's used for them are monoclonal antibodies. Now, when you're making a drug, a chemical, or a biologic, it's two totally different processes, and we'll be coming back to that over and over again. What is the difference between an aspirin, insulin, or one of the medicines I'll be talking a lot about is called Remicade or Infliximab? What are the differences there, and why does it matter? Well, that's really what this whole exercise is about. If we want to make a copy of aspirin, nowadays there are simple ways of getting all of these bits of atoms together to make aspirin. If we want to make a large biologic or monoclonal antibody, like Infliximab, it's not so straightforward. In this figure, you can see a cartoon, if you will, of aspirin and Infliximab. The aspirin is quite small, simple. Everything you're seeing there are all the atoms that come together to make it. And when you add up the weight the way scientists and chemists do, you'll see that it comes in at a number that's about 180. If we take Infliximab, 180 is nothing. It's a rounding error. In fact, it's 144,000 before you even get to the 180. It's huge. It's 1,000 times bigger. We're talking about something that is very complicated. But wait a minute, if it's that big, maybe it's dangerous. But it isn't. This is the kind of protein your body makes all the time. These are like antibodies that protect you from infection. This is what's going on here. These are big and they're complicated. And the amazing thing is, now, over many years, scientists have actually pulled off making these, and they're used to treat many diseases, from inflammation like psoriasis to treating cancers. One of the phrases we often hear in this area is that the process determines the product. What does this mean? Well, when we're making something that's complicated, all the steps you go through can matter, some more than others. Baking is a common example. You can take all the same ingredients, and whether you're making a souffle or something else, it's a process. And that process, if it changes in certain ways, comes out with totally different answers. One of the best explanations I ever had in real life was at a cheese shop, where the person was allowing me to sample cheese. And he gave me 3 different cheeses to taste. One was hard, one was soft, one was sharp tasting. And then he said to me, you know, all of these are made up of exactly the same components, exactly the same amount of milk from the same place, everything. It's just that the process to make them was different. That's what we're talking about when we say that the process determines the product. Here we have some clinical pictures, and on the left are diseases. The first disease at the top is a small picture of psoriasis. If you have psoriasis, you'll know what this is about. But if you don't, it's a scaly condition. It's thick, it's itchy, it's painful, it's always with you. You don't get a day off. It's miserable. People hate it, and people are shunned. On the right of that is the clear skin in the same person. The reason their skin is clear is because they received a biologic medicine. To get a biologic medicine in our current environment, you would have had to be on many other treatments first. You would have been on creams, you would have had light therapy, you would have been on pills. And the reason they received that specific biologic was because those weren't working. And for me, and I've been practicing for a long time now, for me, what I'm seeing today is a miracle. It's things, if anyone had asked me to wish for something other than waving a magic wand and making psoriasis go away, I never would have believed we could treat people so effectively and so safely with the products we have. Underneath that is an example of arthritis, but it's also involving the nail. And when we have arthritis in the joints in the hand, the nail is usually involved. The nail can look as bad as here, where it's got all kinds of yellow discoloration, it's thick, and it's got little holes in it and what we call oil drop stains, and the person has arthritis in the joint. They can't use their hands because of the pain and the stiffness. They say, my hands feel frozen. Also, they can't socialize. When they talk to people, their hands are tucked under their armpits. When they eat, their hands are under the table in public. It's embarrassing, it's humiliating. For many people, this alone is enough to consider a biologic, enough to make them say, look, I need to have my life back. And of course, inflammatory bowel disease on the bottom. Crohn's disease, when you're looking into the bowel and you're looking at these ulcers, all the things that are causing the bleeding, the pain, and the total impact on someone's social life, their sexual identity, their ability to relate to other people, or even plan ahead. These diseases now have been changed dramatically because of drugs like Infliximab. The picture is sort of a cartoon of all the bits and pieces that come together to make a large antibody. In this case, it's an antibody that we're giving to people, a biologic, a treatment to help make them better. One of the issues we're facing today is new copies that are coming out. These are copies of the originals. Some of those originals are named here. Now, these copies are not really copies. They're sort of like if you had a photocopier and you took a picture of somebody. It's not the same. It's a bit different. And how different it is matters. And it mattered a lot to the countries that have health organizations like Health Canada, where they had to decide, how do we manage these? What do we do? Well, it wasn't easy for these big types of treatments. It wasn't easy to figure it out, and it wasn't easy to even come up with guidelines that everybody agreed with. But I think the principles are there. First of all, the naming. In Canada, these are called subsequent entry biologics. Biologics that have followed on a previous biologic. However, internationally, we're hearing the term biosimilar more and more. So when I speak about this, I'll probably be calling them a biosimilar. You'll see the short form SEB for subsequent entry biologic. But in fact, we're really always talking about biosimilars. So please forgive me if I keep changing the name. Let's get back to this baking example. No example's perfect, but I think you get the idea. On the left, you have Twinkies. And you can reach into a box of Twinkies if you remember what these are, or anything like that. And if you pull it out, they're all going to be the same. You're going to look at it and know it's exactly the same. When you try and make a cake, it's different. You can't get them exactly the same. There are differences in the taste, the structure, the size. Does that matter for a cake? Maybe not so much. It did at my daughter's wedding when she didn't get the cake that she wanted. But for other people, it might be perfectly fine. It tastes delicious. Well, it does matter for biosimilars. For biosimilars, when you make small changes, it could have a big impact. When we think of similar things, many of you will have been on a medication. and you went to the pharmacy, and you could be asking for something as simple as aspirin, but you got a different kind of ASA. Does it matter? Probably not. Why not? Well, because these are chemicals, and these are easily synthesized to be exactly the same. And then when they're put into a pill, that changes things a little bit. However, there are what are called bioequivalence studies. You give that pill to healthy people, you measure the aspirin in their blood, and you decide, is this the same as the originator product? That's important. That's something that all manufacturers of generic or copy drugs need to do. It's different for SEBs. We can't do that. We can't measure it in the body exactly the same way. And so what happens is there are many tests that are done by the companies that make these and the agencies like Health Canada that evaluate them to make sure that they're as identical as possible, realizing that they really may not be. They may just be similar, which is another way of saying different. So speaking about Health Canada and the guidelines on biosimilars or SEBs, the kinds of decisions that have to go into this are based on evidence. We hear a lot about that. Doctors like to say, when I make a decision, it's based on facts. Now, we know there's an art to medicine, and we have to make decisions based on individual differences in patients. Yet the original process starts with us knowing the facts. We need to know the rules on the highway. We need to know how to drive a car before we can pick any car. What are the variables that are looked at if you are a regulator like at Health Canada? Well, first you would want to know if you have a drug that's been used usefully in many different diseases, what's the evidence for that? Well, for a drug like Infliximab, there would have been studies that were done. And those studies would have been in people with psoriasis, psoriatic arthritis, inflammatory bowel disease, ankylosing spondylitis, with the view that you wanted to prove that it was useful, it worked, we know exactly how much to use, and we know how to use it. How often? Every 6 weeks, every 8 weeks, what works, what's safe, and then after that it would be studied for a long period of time, looking for side effects in what we call the real world. For the biosimilar, it's a bit different. For the biosimilar, it may just be a small number of patients in 1 or 2 diseases. That isn't ideal. And not every regulatory agency is happy about that. And I have to say, Health Canada has very strongly said that we would not like to extrapolate or make up a fit if there isn't data to support it. Another issue that comes up with biologics, naming. Naming's very important. I was at a meeting that included many patient groups and physicians who were leaders in the areas of nephrology, oncology, cancer, rheumatology, and other areas, and myself in dermatology. And the question of naming came up. Now, I think naming is a big deal. And I was very surprised, impressed, and gratified that the patient groups put it as one of their top 1 or 2 issues. In other words, if I went to buy aspirin and a pharmacist said, well, here's 3 or 4 different ASAs, or acetylsalicylic acid, I could say, well, I don't know, which one's cheaper? So this one's cheaper, it's fine. Ibuprofen, same thing. I could get Advil, or I could get another named brand from a pharmacy, and I could pretty much expect it's going to be the same thing. And if it's cheaper, I might jump at that. That's great. But when you get to the biologics, it's different. With Infliximab, we now have in Canada Remicade and Inflectra. Remsima also was approved by Health Canada. But both of these, or all 3 of these, are named Infliximab. That can matter. It can matter if I had a reaction to one of these medicines. And I reported it to Health Canada and said it was Infliximab. But which Infliximab was it? Health Canada hasn't really decided on how they're going to name these products to differentiate them, though they clearly recognize that there's a need for it. That's important. Why have they hesitated? I think quite rightfully they waited for the World Health Organization to come up with guidelines. If we came up with Canadian guidelines, that wouldn't play very well when we were reporting our adverse reactions or any other important information to the World Health Organization. If every country called it something different, it would be a mess, maybe even a bigger mess than it is now. So we're waiting for the WHO to come up with guidelines. And draft guidelines were indeed enacted in July of 2014. But the final word isn't in yet, but I suspect we're not far from that. When we start finding out what the unique names are, we'll be able to do things that we can't do right now. We'll be able to say, you were on this one, we can't change you to that one because there's a concern changing from one infliximab to another. Or we can say, you're on this infliximab. If something didn't work, or if you had a side effect and we have to report it or consider what to do next, we would know which infliximab it was. In fact, we would also know in which of the few factories in the world it was made. If there was something in the process, and remembering how important that process is, if there was something in the process that was unique to an infliximab made in a country in Asia, or a country in Africa, or a country in Europe or North America, and we knew exactly where it was made, we could go back if those reports were coming in and say, was there anything that changed that mattered, that caused this failure or this side effect? So this whole idea of naming is very important, and important to patients and their families and their caregivers and the people who deliver it. If you're getting a medicine like infliximab and it's given intravenously, you want to make sure that the people who are supplying the pharmacy, the person who's hanging it up, tells you, this is Remicade, this is Inflectra. You need to know. It's very important, and it's up to you to make sure that that's happening because you know how important it is. One of the issues that Health Canada was quite serious about and made it clear was the possible impact of changing one biologic to another version of the same biologic. So let's say infliximab to a different infliximab. Either way, could be the originator to the biosimilar, one biosimilar to another biosimilar, biosimilar to the original, doesn't matter. We're not happy with the idea of changing because there can be subtle differences. And what could happen is that you lose the effect of that drug, or you may have a reaction, and we don't know yet. And for each biologic that has come out, we've always tried to know, but when changes were made, sometimes people were surprised that we lost biologics because of problems. Especially if you had something like insulin, if that was made and caused a problem, then your body would make you allergic to insulin. We couldn't even give it to you anymore. So we have to be very careful with this. One of the questions that comes up, though, is, well, if I'm getting an infusion or if I'm picking it up at a pharmacy or I have it delivered to me, who's deciding? Who can make that change? I have to say sometimes, even with prescription drugs, I get confused about this. The issue is really not simple because even if there was an answer, it's different from almost every jurisdiction. Province by province and territory by territory, there are differences. And in practice, whether it's a distribution center, your community pharmacist, we don't know. People are making decisions. Ideally, the feeling is that if you were going to be changing, it should be made by a physician. Your physician should make that decision. And your physician should know that they would not be changing you from one infliximab to another infliximab unless we have the data that supports that. If we see that, I as a physician would then say, I didn't know that, but I'd like to know, and I'd like to know that on an ongoing basis, year to year, that's still true. Otherwise, if we're with drug A, I want to stay with drug A, and I'm not moving it to drug A star. I want to know that that drug is the same one. I guess all of us are a little bit concerned that those choices might come up and things will change without us knowing about it. And if I was a patient and I as a physician, I'm also concerned about those. There's no standard approach across Canada. Who can make changes is not necessarily clear. One of the groups that you may not think about, we think about the pharmacy, we think about the doctor, think about the physician who might write a prescription that changes it. But what about the person who's paying for it? The people who are paying for it? Whether it's your provincial government or an insurer who's paying for it, what if they tell the distributor, okay, we're not using drug A anymore, we're now using drug B. Change everybody from A to B. That's not right. Health Canada made it clear they did not want that to happen. And I agree with that, and I think all the experts do. This leads us into the idea of biosimilars and looking at it from a global perspective. I talked about all these other countries where these biosimilars are being made, where they're being sold. There have been different attitudes to this kind of change into the biosimilar world. In Europe, there were 20 biosimilars approved in the past 9 years. 20, that's pretty good. 8 of them were withdrawn. Some, there were adverse effects. Some, they lost efficacy. Sometimes they really couldn't prove that they were equivalent to the original. The point is, it's a changing landscape. There's no easy way to do this. Almost anybody can make a new aspirin. And it would go out there, and if they did the tests in 20 adults, they could get it approved. It says, look, it's the same as the ones that are out there. It's not the same with the biosimilars. It's much more complicated, and it does involve a big commitment, not only in making them, which is an expensive and complicated process. It requires a lot of know-how and a lot of control, because the world keeps changing, but also getting it out there and in the people who need it. Not everybody's the same. That's obvious. And yet sometimes approvals aren't made that way. Not everybody's the same. Not all people with psoriasis are the same. But people with psoriasis are different than people with Crohn's disease. We can see that. So what happened over time? Actually, Infliximab had its first biosimilar in Korea. It's a product made by a well-known Korean company, very capable of doing this, does a good job. And it was approved in Korea. In Europe, it was approved a year later, and Canada a year after that. The United States is getting close. They're still not in that game yet. Partly waiting to see what happens, but also coming up with guidelines. And when you make guidelines, you also need to make rules. Because if you make guidelines and people don't follow them, what can you do? So you need to know. If we make this guideline and it's not being followed, how will we know it's not being followed? That's important. And what will we do if it's not being followed? That's important too. And it isn't just important because you say, oh, you can't do this anymore. Well, when you make decisions like that, it has a huge impact on patients. If something goes wrong with biosimilar B and it's taken off the market, and now those people have to be changed back to the original, can we do that? We don't know. So it's a tricky business, and I appreciate that the US is taking time to hopefully do it right. We'll see what happens. And what right is, we don't necessarily know. So Infliximab and Remsima, as I mentioned, are already approved in Canada, and they've been approved for those indications there: rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and psoriasis itself of the skin. Now, for psoriatic arthritis and psoriasis, there were no studies done with either of those new biosimilars of Infliximab. 0 studies that have been published or presented to the authorities. So they gave what would be called an extrapolation there. But they didn't extrapolate completely. They didn't extrapolate to inflammatory bowel disease. And I think they had concerns, and they're trying to iron those out. My understanding is that biosimilars are now going through clinical trials in inflammatory bowel disease to help with that, both for the US and Canada. If you want to look at what's been done and the numbers of it, and this is not the number of patients who've been on the drug. If we look at Remicade, we're talking millions of patients. But if we're talking about the number of people that were in clinical trials and followed very closely, some of these studies can be up to 3 years or 4 years long. When you're looking at that, you're looking at thousands of patients over all those indications, including pediatric ones. When you're looking at the biosimilars, there was an early study done in 125 people with ankylosing spondylitis, and a slightly larger number in people with rheumatoid arthritis. And yet, psoriatic arthritis and psoriasis were approved in Canada without studies in that, and inflammatory bowel disease was approved in Korea and Europe without studies. Health Canada pulled back from that decision. Another way to show it is with these check marks and X's. The reds are the extrapolation, the ones where we had really no data at all. We still don't. Above that, in green, are all the ones where Remicade had been studied and approved based on those studies, and reasonable numbers of patients to draw a conclusion about the dosing, how to use the drug, how much you should give, and how often. In Canada now, we can use biosimilars for rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and psoriasis. The latter two, the ones in red, related to the diseases that I am working with. We don't have studies, but we still can have patients who get those drugs. This is a complicated area. It's complicated for me, and I've been to so many sessions. I've seen so many slide sets. I've heard so many talks. I've been to several places where they make biologics and biosimilars. It is complicated, and I'm beginning to understand it. It's taken a year. but I'm starting to get it. It's a lot, it's a moving target, and I keep up on it. I keep reading it. In the latest or last week's Economist, there was a story about biologics and biosimilars, and there are issues that are brought up about that. Things that say, well, what are the issues we're facing today? Well, patients are going to be looking for information too. And the information patients are going to be looking for are going to be, what's the difference in the treatment schedule? For example, if I'm getting Remicade at a dose, 7.5 milligrams per kilogram, but the biosimilar isn't approved at that dose, what happens to me? Can I get that? That is up to a few different steps, and we don't know who's going to make those decisions or on what basis. They're going to wonder about, what am I dealing with now? Is my insurer changing me? What's happening with my insurer? I can feel people's angst already about this. That's why so many people are listening today. I don't have an easy answer. I have enough challenges dealing with insurers myself. If an insurer is listening, please write in and reassure me that everything is going to be okay. And what about healthcare providers? I don't think anything's going to change there. You may have to change pharmacies. That could happen, but I don't know, and I don't see why. I would hope not. I would hate to lose a pharmacy that's helping you tremendously. I don't see why you'd ever have to change your doctor because of this. We're all trying to work in this environment and protect patients. If we see something that doesn't make sense, we do try and tell the insurers about it, and we also can share that with manufacturers and Health Canada. What about disease education? Those things will still go on, and I hope in enhanced ways. That would be nice to believe in. There's widespread networks across Canada that exist already. New ones will be coming out. The new ones will learn from the mistakes that were made with the old ones, but the old ones took a long time to build and a long time to get it right. And to have the right expert who answers the phone and answers your questions, my nurse's questions, pharmacist's questions, that wasn't easy. We'll see what the growing pains are. We don't know yet. Long-term expertise, it just isn't there. We don't have long-term expertise with these kinds of biosimilars, the ones that are these large antibodies. It's something very new to almost all of us. And some of the experiences that some groups have had have made them nervous. So we're going to try and pay attention and learn as much as we can. I'll leave this up a bit. There's a few links that you could look at if you're interested. Some of these are patient groups, some are other societies, some are patient groups based on disease, a whole bunch. The idea is that we will have this up on the web, we hope, and available for downloading, and I'll leave that to the organizers to make happen. It would be nice, I think, to see under each of these what information they can provide, but I think there's a lot out there, and it's quite readable. It shouldn't be confusing, but it is like studying for an exam. You'll read one and think you understand it, and then you'll read a second and think, that's different than the other one, I'm confused. Welcome to the club. I'm hoping I can remove some of that confusion today. The patients' associations do have positions, though, on biosimilars. There's a lot of consistency there, and consistency with what I've spoken. I've read their comments, and I've read the reviews, and I've heard them speak about their concerns. They talk about having naming right up at the top. They want a safe process. And that process isn't just the process of making the biosimilar. It isn't just the process really of getting everything right in making it, which is what Health Canada sees. It's the process of getting it to you. How do we make sure that that gets to you in a way so it's always the same and it's always going to work for you? And if there's any issues, weather, distance, mail strikes, whatever, you get the drug that you need. We need to make sure that those things are in order, and those things do take time to build. We, as healthcare providers, myself as a physician and specialist, will have to learn more. For general internal medicine and family medicine, they hardly ever use biosimilars like this. They never use them. They almost never use biologics. And if that's the case, what's going to happen to their sense of security if your family doctor doesn't really know exactly what you're taking or whether it matters? A lot of education of healthcare providers is going to have to come, and it's going to be enhanced from what we've already done already. It's been a long, and I think very thoughtful, and for me, a very rewarding process to see even internal medicine specialists start to understand some of these issues and understand how it might play out and what they have to be looking for. Cost comes up as an issue, of course, and that was one of the reasons for making generic drugs. Try to bring down cost. In a way, by having patent limitations, it also should drive innovation. But this is not necessarily that type of innovation. This is an innovation in copying. So an innovation in copying could be important if it brings down the prices. We do know that when looking at the retail prices, there does seem to be a discount. How that will impact all of the facilities and everything that patients and healthcare providers need, we don't know. I keep saying we don't know, and I mean it. We really don't know. What do we think is going to happen? It's a marketplace. I suspect, and I hope I'm even saying it here, that prices will level out. There may not be a difference. All of that is negotiations between manufacturers and the providers who are the insurers, and the provincial health providers who pay for drugs. All of them have to be involved and decide how are they going to manage this and what kind of price or other benefits are they going to be looking for. What is their financial risk management strategy? All of these are being done across the country as we speak. It's something happening now, and it's something that's going to be evolving over the next year. Physicians also have their position on these, whether we wear a stethoscope or a white coat or not. I do neither. What do we think? Well, these quotes are very familiar to me. These are what we say at meetings. Costs must not override safety and efficacy, and they should be regarded as standalone products, biosimilars, not as just substitutes and taking one off the shelf and then saying, nah, I think I'll take the other one. It doesn't work like that. And we're saying that clinicians have to really learn a lot and know about the indications. And if there is no evidence in your indication, but it's been approved, what's happening with that biosimilar? What's the data? What is it in a year? What is it after 1,000 or 2,000 patients have been treated? We need to know this. I hope that information will be collected and reasonably distributed to healthcare providers, to Health Canada, and to anybody else who cares about it. Biotech Canada is a group that works with the public and with industry and with physicians and specialists to try and understand what's going on in the biotech industry. They actually have come out with, I think, a very thoughtful summary of a large meeting. It was a meeting that I mentioned before that contained all the specialists from the areas that are involved, as diverse as dermatology and cancers in children. And the idea there was to really get a lot of input from the specialty groups, from the specialists, and from healthcare providers generally about how is this going to play out? What are our concerns? And I have to say, and I'm putting myself out, this is from my heart, we heard a lot of mechanical things. What about the structure? What about the process? What about glycosylation and understanding what that means? Some of it was very technical. Some of it was very specific to process issues. I had one word. My word was trust. Who do I trust in this? And that's where I sort of fell short. I fell short a little bit thinking, what do I trust? And I have to say for me, and I'm not a big stickler about this, but I trust the data. I want to see the information. Let us all see the information and share our interpretation about it and know what's going on. To me, it is about trust. So some final thoughts before we open it up to your questions. You have questions? Ask your doctor. Is your doctor going to know a lot about biosimilars? Probably not. So what do? Use the patient support groups. Use the advice of what you find online. Biotech Canada is not a bad source for that. I think if you have concerns, you want to raise them. If you think we don't really know, then say so. You deserve to get the best answers you can. And the best answer isn't always a perfect answer or a completely informed answer. It might just be as good as it gets. And if you do want to speak up, I know patient support groups would like to hear from you. I know groups like the Canadian Skin Patient Alliance love hearing from patients. They want to have patients talking to payers about all the issues. They want to have patients talking to governments about how they're funding. They want to look at report cards across the country and make sure that when it comes to biosimilars, that all the payers get an A+, that they're all making smart decisions based on the data. They're getting an A+ because they're getting the answers right. The final decision on which biologic you receive should be yours. It should be yours to make. And at the end of the day, you probably should not be having a conversation where somebody says, oh, but it's saving us money, or you won't reach your cap as quickly. That should not be part of the conversation. That's up to the manufacturers and the insurance agents to talk sense, and it's up to the governments to make sure that it's safe and that things like switches aren't happening. And then if anything does happen, we know the right name so that we can get the right answers to protect you and other people in the future. Remember, the final decision on which one you receive, it's your choice. Thank you very much. So forgive me as I look down at the iPad. I'm not checking anything else. Okay, now this is somebody else talking. I am 56. I wish. Can I take a biologic for my whole life? If I stop, are there withdrawal symptoms? Will my disease relapse? It's a very good series of questions. Whether you're 56 or not, the answers are the same. If I'm treating a disease like psoriasis, that disease will last 30, 40, 50 years. You stop your pill, you stop your biologic, it starts to come back. It comes back slowly, but it comes back. It could take 3, 4 months. Our concern is if you do that, and we learned this early on, we stopped biologics because they were expensive and we wanted to know. And a person said, oh, I'm going away for 3 months to Europe. Can I stop it? Sure, let's try. And then they go back and they don't get the same response again. So we're not happy about that. We want people to stay on their biologic. We really think it's important. We really think it matters. I can't speak to all diseases. We don't know. Some diseases are more intermittent than psoriasis, which is always there. It might be hard to tell. I think that's something you really have to ask your doctor and your specialist about. Ask them, can I take a holiday on this? And if so, what are the risks? But ideally, usually the answer is no. You want to stay on it. The disease will relapse. If my biologic has lots of manufacturing changes, is my biologic different? We hear things about biologics being biosimilar to itself. Let me explain that expression. So if I have 2 drugs, and I mentioned Remicade and a biosimilar. If I have Infliximab, and it's the Remicade, and I said it's so complicated. And if you went to the government and you said, how many changes have there been in that process over the past 10 years? And they look up and they say, oh, there have been 250 changes. You think, oh my God, I heard Dr. Scheer talk. It must have gone in as an apple and come out as a banana. How could this possibly be? If they change anything, if a doorknob gets changed, they have to report it. People are obsessive about reporting any change. That's good. We don't want to punish them for that. That's good. If they said we changed the source of water, or we've got a new cell that's making it, goodness gracious, that's a different story. So there's a different degree to change, but it could happen. So something that was over here starts to go off and become different. What does that mean? They have ways of measuring. There's quality control within the companies. I've seen the data. It's very boring. They're little bars. Every time they test, the bar is the same. They do not change, which is great. Doesn't mean it could never happen, but it does mean they're staying in the same lane and they're driving in the same lane all the time. Just look at the nice new cars. With all this technology that tells you if you go out of the lane, they're staying in the same lane. Okay, so when a biosimilar comes out, it's considered pretty similar. I'm not going to say same, but let's say it's almost the same as the original. And what happens with it? It can also change a little bit over time. But let's say they both stay in the same lane they started in, but the lanes are going somewhere different, and they're moving. So what Health Canada sees today as similar might be less and less similar over time. It might matter. And that manufacturer might also say, no, ours is still very much the same as the original one. but there might be a drift. That's something we're going to be looking at. But does the biologic you have now, the one you're getting, is it changing dramatically? It does not appear to be so. That's not been the case over the last 10, 15 years. This person was on a biologic for 4 years and did develop antibodies. They've been on a different one for 5 months with no sign of improvement. How long should I continue? Is it time to try something else? Well, let's talk about antibodies. When you get an infection, your body makes antibodies to it. It's our way of protecting ourselves. It's the same structure, if you will, with differences, but the same basic idea as the biologic. If you're allergic to something, peanuts, they're antibodies. They happen to be of an IgE type, and those are things that can make you allergic to peanuts. We're talking about antibodies, but antibodies do a lot of different things. In this case, antibodies are not there to fight an infection. They could be. That was used to fight Ebola. But here, what they're being used for is to treat a disease, and they're directed to a very specific target. I can come up to my door at home and fumble around with my keys. I'm sure you've been through this. And you put in a key that looks right, doesn't fit. Another key that looks right, it doesn't fit. And you put in the exact right key. It's so easy, it just opens like nothing. That's what we want with these biologics and the copies, the biosimilars. We want them to be exactly the right key, not the one that somebody did a shoddy job copying at the key store. I don't think we're looking at that here, but that's certainly what we don't want. We don't want that one goes in and almost turns. We want to open that door. So what about getting antibodies to this? Well, when you give a foreign protein to a person, their body might make antibodies against the antibody. In fact, most people getting biologics have some antibodies against that biologic. The question is, does it matter? Some drugs will stop working for other reasons. I might measure antibodies and say, oh, it's because you have antibodies. But it doesn't necessarily mean that's why it stopped working. We're learning more and more that the antibodies may not matter that much, but it often depends on the disease. So, people with rheumatoid arthritis are perhaps more prone to making antibodies against things than people with psoriasis. My patients with psoriasis might make antibodies, but it may not affect what they're getting if they're getting a biologic. Antibodies may exist against that biologic, but they don't really matter that much. However, perhaps in rheumatoid arthritis they do. And you'll see a split. Some doctors will have patients on a medicine like methotrexate to reduce the antibody coming up, to reduce something diminishing the biologic. I do that sometimes too in my patients, and sometimes maybe it doesn't work. And we do consider it could be antibodies. There's different ways of dealing with that. We can add another thing to try and get rid of the antibodies, or we can change to a different biologic. And when that different biologic doesn't work, it may well be that you just don't have the right biologic yet. You've gone through 2 keys and they weren't the right key. You're waiting for the right one. And it may well be there, but you're going to have to try it. How long should you wait? I don't know. I wouldn't want to wait. But that's not the right answer. The right answer is you've got to give it a chance. If there's a way to optimize therapy, if there's a way to get the best out of it, give more. Give it more frequently. Maybe give another medicine with it, like methotrexate, or maybe you're already on that, give a bit more methotrexate. There are different ways to look at that. We want to optimize it. When we've given that a good shot, it could be anywhere between 3 to 6 months. It's not worth going on, and you think of changing. But it's different. It depends what you're adding and how you're doing it. Again, a conversation you should be having with your specialist. It's a very important question, and I don't think there's a cut and dry answer. But I hope I touched on some of the issues about sometimes needing just the right key, and the fact that you do have to try a few things once you have a key to optimize it. How can an SEB or biosimilar be permitted when no studies are done for psoriasis and psoriatic arthritis? How can that be safe? I don't know. I didn't make that decision. Is it a good guess? May well be. Health Canada said they would do it based on biological similarities. I just told you, for me, psoriasis and rheumatoid arthritis are very different diseases. Ankylosing spondylitis and psoriatic arthritis, they do have some overlap, but they're very different diseases. They're different individuals. And when I say different diseases, People's entire being is different. Their risks in life are different. All of that, I think, should factor into decision. So I didn't make that decision. I had no pressure to make a decision. But it's allowed, and that decision was made. Somebody who's itchy all over their body, well, boy, there's so many causes of itch. I could run an itch clinic day and night, and probably within the first hour, I'd be scratching myself to bits watching people. It's not a fun thing to have itch. Itch is miserable. You really need to see a dermatologist. It may not be psoriasis, it may be a bunch of things. If we're talking about psoriasis, then treating your psoriasis will get rid of the itch. We've got pills for that. We've got creams and light you've probably tried, but there are pills for that. There's new pills. There's biologics, treatments galore to try. And once you get your psoriasis under control, the itch should go away. Is it safe to take a biologic more frequently than the usual timing? Well, it may not be safe for your bank account, because if you're going to start doing that, that could be expensive. The idea is that for most biologics, which are antibodies, that you're down to about half the level after 3 weeks if you're measuring it, maybe even 4 weeks. If you're looking at the effect could be for 3 days. The effect could be for 3 months, depending on your target. What is that antibody targeting? So is it safe to take it more often? There are pretty strict rules about that. So for some things, I say, no, you need to take this twice a week. But for other ones, I say, you can take this every 6 weeks. Isn't that exciting? It's different. You can't compare one to the other. There's no single answer. Again, a discussion to have with your specialist, but something that might work for you. Is there a cost saving for biosimilars? That's the idea. The idea is that there's a cost saving. If there is indeed a cost saving, one would think something has to go. I'm not sure what that would be. Would it be support programs? I hope not. We need them. Would it be the quality of support programs? Again, I hope not. Ultimately, though, it is a decision that's being made by payers, who are insurance companies, or provincial formularies, provincial ministries of health, who are making a decision about what they're going to pay. And all of those payers will have that discussion with the manufacturers, and then it's an economic discussion. How do we make all this work? Not just for you individually, but for a whole province. How do you decide in a given province what you can afford and what you need to save, and how can you make it so that it's economically feasible and rational to move forward? Times are changing a bit with the economics. Things may become tougher. So we can expect there's going to be a lot of debate that neither you nor I are probably going to be involved with. This is a very interesting and good question. Do SEBs have different formulations than the originator? When you think of a biologic or any drug, we like to think of what is the structure of that. So ASA or aspirin, exactly the same. But then you want to think about what it's in. I mean, frankly, if I put ASA in a bowling ball, it's different than if it's in a pill. It's just not going to work. So exactly, that's part of the formulation of what's going on. However, if a drug like Infliximab is given intravenously and a drug like adalimumab is given subcutaneously, Humira, you could expect the biosimilar is going to be given in the same way. And you could expect that when they make the vehicle that's going to be carrying that biosimilar, it has to not only keep the biosimilar stable, and the conditions about how cold it could be or shouldn't be have to be clearly described. If there's a change there, that's a big deal, because if someone's used to doing something with the originator and they have to do it differently with the copy, it could make it ineffective. So those issues have to be looked at. And also, when you're putting an injection in, you don't want it to sting. When you're getting intravenous going in, you don't want it to burn. What if there's something there? That's why you want those studies. You want to know if those things are happening. And if they are, you have to change that formulation. Ideally, the formulations will be similar. You'll be able to tolerate them as well, but they will be different. Do any of the biologics affect a patient with hypertension? Well, high blood pressure, there are many degrees of hypertension and many drugs you might be on. Generally, depending on the biologic, sometimes reactions do occur. There are some that I use for some types of cancer and other very severe skin diseases where we might need to pre-treat a patient, worry about them getting an allergic reaction, not the ones we were talking about today. I need to know if they're on the so-called beta blockers because it might be harder to treat a reaction. So it really depends on the biologic or the biosimilar, and again, a conversation is required. Generally, it probably should not be a deal. If you're getting it intravenously, they will check your blood pressure. They will tell you if there's a change, and that would be important to feed back to your doctor. Why does some insurance company require an X-ray with evidence of active ankylosing spondylitis to improve Biologic A when not of Biologic B? Now, I would think in this scenario, and I'm not an expert, Biologic A is a totally different biologic than Biologic B. And yet, the request is different. Ideally, that information should be based on evidence. So it may be that Biologic A did a study, and that study showed that it worked best for, or other literature showed that it worked best for, people with active ankylosing spondylitis. And Biologic B may not have had that evidence or shown, even better, that it worked whether it's active or not. I don't know. And it could be based on an economic decision. When a doctor prescribes a biologic for you, and I send in all the forms, we fax them in with your consent, and we get back a form either from a support program or the insurer themselves, and it asks us questions. And it may say, this patient cannot be on Biologic A unless they failed Biologic B. We've done a survey. We asked doctors, how many of you think that decision is based on medical evidence? Doctors thought it was. It is not. It might even be in contrast to medical evidence. It's purely economic. It's basically saying we can get Biologic B cheaper. That's what we're going to give you before we consider Biologic A. So there are many factors that go on, if you will, behind the scenes. And there are many insurers. And somebody could say, I speak on behalf of an insurance board in Canada. We never do, please. That's all I have to say. Is there a chance for patients to go off a biologic back to NSAIDs if remission is obtained? Well, I'm thinking we're talking about arthritis here. It could happen. We do see it. We do see patients who move, decide to go off a biologic for whatever reason. We've had biologics that have been withdrawn from the market because they were working, but they start to have side effects and they weren't that competitive with some of the new ones. Then sometimes patients go back to simple medications. It can happen. Often when patients are clear, depending on the disease, and if they've got support for it, they don't want to go back. How do you know if you've developed antibodies to a biologic? I can tell you the answer to that. You're getting a biologic. You probably have some antibodies to it. That's not the question. The question is, does it matter? It doesn't. Most of the time, it really doesn't matter. Do we have biologics, antibodies to biologics that are truly neutralizing? If that's what you're asking, that's not so easy to figure out. And companies are doing studies with that all the time, and new assays keep coming. We don't have any way to compare them. We are still in the dark about that. The only way you can tell that you have neutralizing antibodies is to consider it. If you're getting your full dose, you're giving it to yourself or you're getting it intravenously, you know you're getting it, and it just stops working. That's the best way to consider it. It doesn't necessarily mean it's an antibody. Should biologics and biosimilars be combined with methotrexate, or a similar drug, I suppose? I don't think it has to be. We don't do that in dermatology. We don't feel that it's necessary in our patients. I can't speak for rheumatoid arthritis or ankylosing spondylitis or inflammatory bowel disease. It may be. The way we often see it is when I have a patient who's on methotrexate, we're weaning them off it and starting them on a biosimilar. They clear up completely. Their dreams have come true. They say, I'm staying on the methotrexate. I don't want to lose effect. I want to be on the methotrexate as well. Is that okay? Absolutely. We're very comfortable following that combination. Finally, how do I make an informed decision on which biologic to take? That is very difficult. I have to say, I've seen a lot of ways of communicating information to people. I've seen 15-page pamphlets with tons of information and ways of little happy faces and sad faces. And I've given it to people who are information intense, lawyers. So I say, hey, look at this. What do you think? And they read it, they come back, they go, no, no, you tell me what to do. Is it really just up to the doctor? Is it really just up to the payer? It's a conversation that well over 50% of doctors, and we've done this study, want to have with the patient. Read about it, but keep an open mind. You don't have to make the decision. And often, clarify what you think. I've had people say, oh, I picked that drug. And I was surprised. I said, why that one? And they told me why. And they were thinking of another drug. The reason they were taking it was because, I don't know, they saw it on TV, they liked the sound of the name, but they really wanted another drug. It's a discussion that should happen between a patient and their healthcare provider, and ideally your specialist in my mind. Thank you very much for your time tonight, and I appreciate your questions and interest.